Welcome to the deep dive. If you're tuning into this, you're probably a medical student, maybe a junior doctor, a public health trainee, or an allied health professional.
Yeah, you're someone who's either standing right on the front lines of healthcare or preparing to.
Exactly. And because of that, you need to understand not just what is happening in the global health landscape, but really why it's happening, and critically, how we actually go about measuring it.
Right, the measurement part is huge.
It is. So I want to set expectations right out of the gate here. This is not a casual summary, and it is certainly not a simple, dry regurgitation of textbook facts.
No, absolutely not.
Think of this as your structured conceptual companion to Chapter 5.17 of the Oxford Textbook of Global Public Health. Today, we are exploring the methods behind the Global Burden of Disease Study.
The GBD.
Yes, the GBD. I highly encourage you to read that specific chapter alongside this audio journey because our goal here is to help you build the mental frameworks required to truly grasp this incredibly dense material.
That is the perfect way to frame it, honestly. Our objective today is to strengthen your clinical reasoning and your pattern recognition, but at a population level.
Right.
When you're doing rounds on the wards, or perhaps later in your career, when you're drafting health policy for a whole district or a nation, you aren't just looking at isolated data points or individual patient charts.
No, you're looking at a massive, breathing, interconnected system.
Exactly. And if you want to understand, let alone fix a system of that magnitude, you fundamentally need a way to measure it accurately.
So let's start by giving you an overarching metaphor to hold on to for the next hour or so. I want you to imagine a ledger.
Like an accounting ledger?
Right, but instead of a global financial ledger that tracks currency, dollars, euros, and cents, I want you to imagine a universal ledger of human health.
I like that.
In this specific ledger, you are still trying to balance a budget, but the currency you are tracking is human time.
Time specifically stolen by premature death.
Right. Yes. Time stolen by premature death, and time that has been burdened by suffering, illness, and disability. This is the very essence of the Global Burden of Disease Framework, the GBD. It's a systematic, rigorous, and entirely scientific effort to quantify the comparative magnitude of health loss across the entire globe.
And to really appreciate this ledger, to understand why it matters, we have to understand the why. Like, why did anyone go through the agonizing mathematical trouble of building this universal ledger in the first place?
Right, because it sounds exhausting.
It is. But if we look at the historical context of public health data before the original GBD study was commissioned by the World Bank, this was back in the early 1990s, the landscape was, quite frankly, chaotic.
Completely disjointed.
Exactly. Without a unified, centralized ledger, you had incredibly well-meaning advocates, professional organizations, and researchers all producing their own isolated estimates of mortality and morbidity for their specific focus areas.
And it makes total sense from human nature, doesn't it? If you are a leading global expert on, let's say, a specific infectious disease like malaria or a non-communicable condition like diabetes, you are looking at the entire world exclusively through that specific lens.
Yeah, your whole career, your patients, your research, it all centers on this one disease.
Naturally, you want to highlight the severity of that disease to secure vital grant funding, public attention, and those very limited government resources.
Of course you do. The incentives were heavily skewed toward maximizing the perceived impact of whatever disease you were championing. But this led to a massive systemic problem of exaggerated claims.
How exaggerated are we talking?
Well, in the late 80s and early 90s, if you took all the independent published estimates of deaths from various commercial groups, professional societies, and global advocacy groups, and you simply added them all up, the total number of claimed deaths mathematically exceeded the actual number of human beings who had died on Earth that year by a massive margin.
Wait, really? So if, hypothetically, 50 million people died globally in a given year, the sum total of all the advocacy claims might have been 80 or 90 million deaths.
Precisely. You had wildly implausible claims because everyone was operating in their own silos.
Yeah.
They're using entirely different methodologies, different baselines, different diagnostic definitions.
Different sampling methods entirely.
Right. The original GBD framework was developed to solve this exact chaos by enforcing a fundamental, unbreakable law of internal consistency. That law is incredibly simple. You only die once.
You only die once. It sounds almost comically obvious when you say it out loud, but mathematically, as a foundational rule for a global database, it's profound.
It's the absolute bedrock of epidemiology. The sum of all cause-specific deaths must strictly equal the total all-cause mortality envelope.
The mortality envelope.
Right. If a death is attributed to one primary underlying cause, it cannot simultaneously be attributed to another just to boost the statistics for a different advocacy group. You have to establish the total absolute number of deaths in a population. First, that's the envelope. Once you have that envelope, you slice the pie. You cannot just keep baking new imaginary pies to accommodate everyone's claims.
That is such a crucial concept. So our mission for this deep dive is to unpack exactly how public health leaders quantify this illness, disability, and premature death across entire populations and nations, despite the incredibly messy data they have to work with.
Messy is an understatement.
Truly. We are going to ensure that by the end of this discussion, you walk away with a crystal clear conceptual framework regarding risk, exposure, outcomes, and systems thinking. So let's move right into section 1.
Which is the transforming global landscape and the epidemiological transition.
Exactly. This is a crucial starting point because the GBD doesn't just take a static snapshot. It tracks changes over time. And the global health landscape has undergone a massive, rapid transformation over the last few decades.
We are witnessing a profound demographic shift. People around the world, on average, are living much longer than they ever have in human history.
Populations are aging.
Yeah, and thankfully, due to massive public health campaigns, vaccination, sanitation, many countries have made remarkable progress in plummeting their child mortality rates.
But that demographic victory creates a new epidemiological reality, doesn't it? If we look at the demographics versus the epidemiology, we see a massive pivoting of the global burden.
A total pivot.
Historically, going back a century or more, the burden of human disease was heavily dominated by communicable, maternal, neonatal, and nutritional diseases. And these primarily tragically affected young children.
Right.
But as child mortality drops and those children survive to adulthood, and as adults live into their 70s and 80s, the leading causes of death and disability inevitably shift.
They shift dramatically toward non-communicable diseases, or NCDs, in adults. We're talking about cardiovascular disease, cancers, chronic respiratory diseases, and diabetes. This is what we call the epidemiological transition.
But I want to pause here for a second because this is where the textbook often loses people who assume this is just a uniform global phenomenon.
Oh, it is absolutely not uniform.
There are massive, complicated regional nuances that the GBD exposes.
That is a vital point to make. The epidemiological transition does not happen everywhere all at once or at the same speed. In high-income countries, the transition is largely mature.
Right.
Those nations are currently dealing with expanding health budgets driven almost entirely by aging populations, chronic NCDs, and the incredibly complex, expensive medical technologies required to manage them.
But if you look at sub-Saharan Africa, for instance, the GBD data shows a very different reality.
Very different. They are still actively battling what public health experts call the unfinished agenda.
The unfinished agenda being the communicable, maternal, newborn, and nutritional diseases that still heavily dominate their specific regional landscape. Conditions like malaria, HIV/AIDS, tuberculosis, and neonatal sepsis.
Exactly. And then you have the situation in many low and middle income countries, the LMICs, which are caught right in the middle of this transition. They're facing an incredibly complex and expensive collision. In global public health, we refer to this as the double burden, or sometimes the triple burden of disease.
Let's paint a picture of what that double burden actually looks like on the ground for a healthcare worker. Imagine you're in a regional hospital in a middle-income country.
Okay.
In the infectious disease ward, they are still actively fighting poverty-related communicable diseases. They're treating drug-resistant TB or managing seasonal malaria outbreaks.
Right.
But simultaneously, because their population is urbanizing, changing their diets, and living longer, the very same hospital is seeing a massive rising tide of patients coming in with acute strokes, advanced diabetic nephropathy, and severe ischemic heart disease.
It creates an agonizing dilemma for health systems and policymakers in those regions. I mean, how do you possibly allocate a severely limited national health budget?
You can't just abandon one for the other.
Exactly. You have a health system that historically might have been designed and built almost entirely around treating acute infections and diarrheal diseases in children. Now, almost overnight, in epidemiological terms, that same system has to rapidly scale up to handle chronic, lifelong, non-communicable diseases.
Diseases that require continuous medication, specialized surgical interventions, long-term rehabilitation.
Yes. Which brings us to the clinical relevance of all this. Why does a junior doctor, a medical student studying for board exams, or a public health trainee actually need to care about this macro-level epidemiological transition?
Right, why isn't this just trivia for health economists?
Yeah. Because this macro-level shift dictates exactly what you're going to see walking through the clinic doors. It dictates hospital funding allocations, it dictates global drug supply chains, and it dictates the exact types of pathologies you'll be treating on the wards over the next 10 to 20 years of your career.
If you don't understand this macro-level shift, you simply cannot prepare for the daily reality of your clinical practice.
It demands systems thinking from clinicians. You aren't just treating a single patient in a vacuum. You're interacting with a population that is in active transition. And to navigate this transition, to know whether we are winning or losing, we need incredibly precise metrics.
That perfectly sets up Section 2. Health expectancies versus health gaps. This is where we really build the core mathematical and conceptual framework of the GBD.
There's math behind the ledger.
Exactly. I want to pose a fundamental question, the kind of question that breaks standard epidemiological models. How do you mathematically combine a sudden fatal heart attack in a 6-year-old with a 40-year-old patient who lives for 3 decades with severe, chronic, debilitating back pain?
It's a great question.
How do you put a quick death and decades of suffering onto the exact same ledger?
It is the ultimate apples to oranges problem in public health. To solve it, it requires translating radically different types of health loss into a single common currency. And as we established with our ledger metaphor earlier, that currency is time.
Time.
Right. There are 2 main classes of population health measures that epidemiologists use to attempt this translation: health expectancies and health gap measures.
Let's break down health expectancies first, because this is a term almost everyone has heard in passing. Most people are familiar with the concept of life expectancy.
Yes, life expectancy is the absolute foundation of demographic health measurement, but it's often misunderstood. Technically speaking, demographers calculate life expectancy by applying currently prevailing age-specific mortality rates to a completely hypothetical birth cohort.
And they use a mathematical tool called a life table to do this.
Correct.
Let's unpack that for the listener. What does that actually mean in practice?
Okay, imagine a hypothetical group of 100,000 babies, all born on the exact same day this year. You track this imaginary cohort from birth. You apply the actual mortality rates that exist right now for infants, then the mortality rates that exist right now for toddlers, then teenagers, and so on.
Applying the current risk of death at each age interval.
Exactly. You track them until a top age category where everyone in this hypothetical group is assumed to have died. You average out the total number of years lived by the entire group, and that number is your life expectancy at birth.
And it's generally interpreted by the public as the average number of years a child born today can expect to live.
Right. But there's a massive assumption baked into that interpretation, isn't there?
A huge assumption. That common interpretation only holds true if the mortality rates at every single age group remain perfectly frozen in time for the next century.
Which they won't.
Right. It assumes the risk of a 50-year-old dying today is exactly the same risk that newborn will face 50 years from now.
In reality, thanks to medical advancements in public health, mortality rates are generally declining over time. Therefore, the true, actual life expectancy of a child born today is usually significantly higher than the published statistic suggests, because the statistic doesn't project future medical breakthroughs.
Still, it remains an incredibly popular metric because it elegantly summarizes a massive, complex mountain of mortality data into one intuitive, digestible number.
It does. But life expectancy has a glaring blind spot. It only tells us about mortality, it tells us the quantity of life, but it tells us absolutely nothing about the quality of those years.
Right. If a population lives to 85 but spends the last 20 years of life bedridden with severe dementia and osteoarthritis, a simple life expectancy metric makes them look incredibly healthy.
Which is misleading. That's where health expectancies come in. They attempt to adjust the life table to account for the loss of health from non-fatal conditions.
We want to know not just how long people live, but how long they live in good health. The coarsest, most basic version of this is called disability-free life expectancy, or DFLE.
But DFLE is a very blunt, dichotomous measure. You're essentially categorized as either disabled or you aren't. If your functional limitation crosses a certain arbitrary threshold, all of those subsequent years simply do not count toward your DFLE.
It's way too black and white. Human health doesn't work like an on-off switch. A person with mild asthma is not experiencing the same loss of health as a person with quadriplegia, but a blunt metric might treat them both simply as not disability-free.
That is precisely the flaw. So a much more refined version was developed, called Health-Adjusted Life Expectancy, or HALE. You will sometimes hear it referred to as Healthy Life Expectancy.
How does HALE improve on it?
HALE improves on DFLE by grading the severity of disability across a continuous spectrum. It takes the life table we discussed earlier, and it adjusts the time lived at each specific age interval by the severity-weighted prevalence of disability in that age group.
Okay, so a year lived in perfect health counts as one full year.
Yes. And a year lived with a severe stroke might only count as a fraction of a healthy year.
HALE sounds fantastic on paper. It gives you a single, comprehensive number for population health that a busy health minister or a policymaker can easily understand. You can use it to rank different countries against each other or track whether a single population is getting healthier over a decade.
But there is a catch.
Always a catch.
A critical limitation. Health expectancies like HALE are excellent for a macro-level dashboard snapshot of a population, but they are mathematically terrible for attribution.
Attribution meaning figuring out exactly who or what to blame for the health loss.
Right. It's incredibly difficult to take a country's HALE score, say 68 healthy years, and reverse engineer it to attribute that specific loss of healthy life back to underlying specific diseases, injuries, or behavioral risk factors.
You know, health is bleeding out of the system, but you can't easily mathematically say 10% of this loss is due to traffic accidents and 15% is due to lung cancer.
Exactly. And that profound limitation is exactly why we need the second class of metrics, which is the beating heart of the GBD, health gap measures.
This requires a conceptual leap. Instead of just looking at how many healthy years we expect to live from the ground up, we flip the perspective. We measure a population's current health against an aspirational ideal standard.
The ideal standard being a world where everyone lives until a ripe old age, completely free of any disease or disability.
The difference, the literal gap between your current population's messy reality and that perfect ideal standard is the burden of disease.
And the specific metric used to quantify this gap is the DAILY, the Disability-Adjusted Life Year. The DAILY is the absolute cornerstone of the GBD framework.
Because it measures a gap, it allows us to meticulously divide up that gap and express the contribution of specific diseases, specific injuries, and specific risks as a precise proportion of the total burden.
This brings us to the core equation of the entire framework. If you are taking notes, this is the equation you absolutely must commit to memory. DAILY equals YLL plus YLD.
Let me repeat that and break it down. A disability-adjusted life year, the DAILY, equals years of life lost to premature mortality, which is the YLL, plus years lived with disability, the YLD, fatal health loss plus non-fatal health loss.
By combining the YLLs and the YLDs into this single metric, the DAILY, we've finally solved the apples to oranges problem. We can now compare that sudden fatal heart attack we mentioned earlier, which generates a massive spike of YLLs, directly against 3 decades of severe back pain, which generates a slow, steady accumulation of YLDs over time.
They are now both quantified in the exact same currency of lost human time.
Yes.
To really cement this, let's walk through a hypothetical patient scenario to see how a DAILY is actually calculated. Let's invent a patient. We'll call him Patient Thomas.
All right, Thomas.
Thomas is a 45-year-old construction worker. Tragically, at age 45, Thomas suffers a severe ischemic stroke. He survives, but he's left with significant right-sided paralysis and aphasia, meaning he has trouble speaking. He lives with this severe disability for exactly 10 years and then passes away from complications at age 55.
Okay, let's open the ledger for Thomas and calculate his individual dailies. We have 2 sides of the equation to fill. The YLD for his time alive with the stroke and the YLL for his premature death. Let's start with the YLD, the years lived with disability.
Thomas lived for 10 years with a stroke.
But a year with a stroke is not equivalent to a year being dead. So we have to apply a severity weight. Let's say, for the sake of simple math in this example, the disability weight for a severe stroke is 0.5 on a scale of 0 to 1, where 1 is death.
So we take his 10 years, lived with the condition, multiply it by the severity weight of 0.5, and we get 5 YLDs. Thomas generated 5 years, lived with disability.
Correct. Now we calculate his premature death, the YLL. Thomas died at age 55. To calculate years of life lost, we have to compare his age of death to the ideal standard life expectancy.
As we will discuss in a moment, the GBD standard life expectancy is 86 years.
So Thomas died at 55. The ideal standard is 86. 86 minus 55 gives us 31. Thomas generated 31 YLLs, or years of life lost.
Now we simply bring the two halves of the equation together. Daily equals YLL plus YLD. Thomas's 31 YLLs plus his 5 YLDs equals a total of 36 dailies.
That single stroke in that single patient added 36 disability-adjusted life years to the global burden of disease ledger. And the GBD simply scales that exact math up to 8 billion people.
It's an elegant, highly functional equation, but as you transition from the math to the theory, you realize that the inputs for that equation are incredibly complex.
Which brings us directly into Section 3, the philosophy of math. Because the daily, as objective and cold as it looks on a spreadsheet, is not just pure mathematics.
Not at all. The massive GBD 2010 update fundamentally reevaluated how these numbers are generated. They realized that the daily is actually a collection of profound ethical, moral, and philosophical choices about the social value of human time.
And for the 2010 study, they didn't just ask statisticians. They convened a panel of ethicists and moral philosophers to review every single one of these underlying choices.
This is where the rigid science of public health intersects deeply with moral philosophy. Let's look at the first inevitable controversial choice they had to make, establishing the standard length of life used to calculate the years of life lost, the YLLs.
Remember our example with Thomas? We subtracted his age of death from 86. Why 86? A health gap measure inherently requires an ideal standard to measure against. But who gets to define what ideal human survival looks like?
The old approach, utilized in the earlier GBD studies from the 90s, used a standard life table based essentially on Japanese life expectancy, specifically utilizing something called the Kollé and Domeny tables.
Because at the time, Japan had the longest-lived population in the world.
Right, but what was intensely controversial was that they established two different standards. They set the ideal standard life expectancy at 82.5 years for women and only 80 years for men.
They postulated, based on demographic observation, that there was an inherent, immutable biological difference in maximum life expectancy between the sexes.
But for the 2010 update, the panel of ethicists fundamentally rejected this dual standard. They argued that from a purely normative ethical standpoint, there was no clear, justifiable rationale for cementing a difference between males and females as the ultimate ideal standard of human potential.
Right. Why should a man's lost year of life be measured against a lower bar than a woman's? So they threw out the dual tables and created a new, unified standard life table.
They scoured the data for the lowest observed mortality rates in any age group across any global population greater than 5 million people.
And based on combining those absolute best-case scenarios from around the world, they set a new, aspirational standard life expectancy of 86.0 years at birth for both sexes.
Wait, hold on. Let me play devil's advocate here, because a medical student listening might be scratching their head. Biologically speaking, across almost every society and even in many mammalian species, females do tend to outlive males.
Yes, there are hormonal and genetic protections at play.
So why would a rigorous scientific body throw out observable biological reality and set them both to 86? Isn't that just ignoring the science for the sake of philosophy?
It is a valid critique, and believe me, it was fiercely debated. But the ethicists countered with a philosophical argument about equity. The GBD is a tool for measuring health loss to drive policy. If you set a lower biological ceiling for men, you're mathematically accepting a certain amount of male mortality as natural and therefore unpreventable.
Ah, I see.
The panel decided that an aspirational normative standard, the goal we are striving for as a species, should be egalitarian. It's a value judgment that the ultimate potential lifespan should be viewed equally, even if biology currently presents different hurdles.
And this concept of equity extends geographically as well, right? 86.0 years applies to everyone, everywhere.
Yes, and this represents another core ethical pillar, egalitarian weighting, the principle of comparing like with like. If a 20-year-old dies of malaria in a high-mortality region in sub-Saharan Africa, that premature death generates the exact same number of years of life. Loss 66 YLLs as a 20-year-old who dies in a car crash in a low-mortality, high-income city like Tokyo or New York.
The loss of human potential is valued equally on the global ledger, completely regardless of the socioeconomic geography where the death occurred. A year of lost life is a year of lost life.
That is a powerful, democratizing value statement. Now let's talk about the other side of the equation, the YLDs, years lived with disability. To calculate this, as we saw with our hypothetical patient Thomas, you need a severity weighting for every single disease, injury, and sequela known to medicine.
We call these disability weights, or DWs. They run on a continuous scale from 0 to 1, where 0 represents a state of perfect health with no loss, and 1 represents a total loss of health, mathematically equivalent to being dead.
But how on earth do you decide that a stroke is a 0.5 or blindness is a 0.2?
The evolution of how these weights are determined is one of the most fascinating methodological shifts in the study. In the original 90s GBD, the old way relied on small, exclusive panels of international health experts and physicians.
Right. They gathered in rooms and used a complex cognitive method called person trade-off to value a small set of indicator conditions, and then they essentially interpolated or guessed the weights for the rest of the diseases based on those benchmarks.
It sounds incredibly elitist. You have a handful of healthy, highly educated doctors in Geneva or Washington, D.C., sitting in a conference room deciding exactly how much suffering a farmer in Bangladesh is experiencing from a neglected tropical disease.
It was rightly criticized for being too reliant on the subjective clinical opinions of a small, unrepresentative group. It was a massive vulnerability in the methodology.
So for the 2010 revolution, they radically democratized the process. They bypassed the experts entirely and went directly to the global public.
They conducted massive, unprecedented population surveys to determine these weights. We're talking about interviewing over 30,000 regular respondents across diverse nations: Peru, Indonesia, Bangladesh, Tanzania, the United States, plus an open-access web survey that reached people in 167 different countries.
But how do you ask a mechanic in Peru and a teacher in Tanzania to assign a numerical mathematical weight to a complex medical condition they might have never heard of? If you use dense medical jargon like diabetic neuropathy, they won't know how to rate it.
You can't use jargon. To make this work across such vast linguistic, cultural, and educational divides, they had to drastically minimize the cognitive burden on the respondents. So they adopted a simplified, highly structured method of pairwise comparisons using incredibly brief lay descriptions.
They mandated that the description of every health state had to be under 35 words, written in plain language.
Yes. They would present two different health states to a respondent, describing the functional limitations and the symptoms, and simply ask a binary question: who is healthier?
So they might present something like, Person A has a constant ringing in their ears but can go about their daily life. Person B feels profound sadness, cannot get out of bed, and feels their life is worthless. And they just ask the respondent, who is healthier?
Exactly. And by asking that simple "who is healthier" question millions of times in different combinations across 30,000 diverse people, the statisticians were able to anchor the responses and generate a highly precise, universally agreed upon spectrum of disability weights for hundreds of specific health states.
I genuinely marvel at the precision and the consensus they achieved here. The data showed that across all these different cultures, human beings generally evaluate the severity of physical and mental suffering very similarly.
Good.
For instance, mild hearing loss or a mild infectious disease episode sits at the very low end of the spectrum with a weight of 0.005. But the acute severe psychotic phase of untreated schizophrenia was assigned a devastating disability weight of 0.756. That is approaching the mathematical value of death.
It quantifies the severity of the lived human experience based on global democratic consensus, rather than just isolated clinical opinion. Now, while the survey teams were updating the weights, the panel of ethicists made another massive intervention.
Right.
They decided to completely reject and remove two controversial mathematical concepts that had been deeply embedded in previous versions of the GBD: discounting and age weighting.
Let's unpack those, because they sound highly technical, like accounting terms, but they are actually profound moral judgments hidden in the math. What is discounting in the context of public health?
Discounting is a concept borrowed directly from economics and finance. In finance, a dollar today is worth more than a dollar 10 years from now, due to inflation and investment potential. When early epidemiologists applied this to a future stream of lost human health, it meant you mathematically valued immediate health loss more than health loss that occurs in the future.
The older GBD studies used a 3% instantaneous annual discount rate.
They did.
Let's look at the math of that. What does a 3% discount rate actually do to the ledger?
It has a drastic effect, especially on children. Let's say an infant tragically dies at birth. Without discounting, that infant loses roughly 86 years of standard life expectancy. That's 86 YLLs.
Right.
But with a 3% discount rate applied to their future unlived years, the math aggressively decays the value of the years further in the future. So instead of 86 YLLs, the discounting math reduced that infant's death to only about 30.5 discounted years of life lost. The older you get, the less your future years are worth.
That feels incredibly callous. And what about age weighting?
Age weighting was arguably even more controversial. It gave fundamentally different values to a single year of healthy life, depending entirely on the person's age at the time they lived it. A curve was applied where health loss in young adults, say, a 25-year-old was valued much more highly than the exact same health loss in an infant or an 80-year-old.
The underlying sociological argument was based on human capital.
Yes. The architects argued that young adults are in their prime productive years. They have a critical social duty and economic responsibility to provide for and look after both the dependent young and the dependent elderly. Therefore, from a societal perspective, maintaining the health of a 25-year-old is somehow more valuable to the functioning of society than the health of a retiree.
You can immediately see why the ethicists threw those concepts out. They were ethically fraught, to say the least. Imagine being a health minister trying to explain to the public or to a patient advocacy group that a year of a 25-year-old's life is mathematically deemed worth more than a year of a 70-year-old's life, or that an infant's death is discounted.
It violates the core medical ethic that all lives have equal intrinsic value.
Exactly. The panel concluded that incorporating societal productivity into a pure measure of health loss was a category error. Dropping discounting and dropping age weighting made the daily significantly more transparent, more fiercely egalitarian, and much easier to explain to policymakers.
Under the new rules, a year of lost health is a year of lost health, completely, regardless of when in the future it occurs, or how old the person is when they lose it.
There's one more crucial methodological shift in Section 3 we need to highlight before we move on to how the data is processed. The massive shift from an incidence approach to a prevalence approach for calculating YLDs.
This is a critical differentiation for your conceptual framework, especially for the medical students listening. Let's define the terms. Incidence is the rate of new cases of a disease occurring in a specific population during a specific time period. Prevalence, on the other hand, is the total number of existing cases, both old and new, living with the disease at a specific point in time.
Previous GBD studies in the 90s used an incidence approach. If you were diagnosed with diabetes in 1995, they calculated the entire future, lifelong stream of health you were projected to lose from that diabetes, and they assigned all of those future dailies to the year 1995.
The argument was that it aligned well with measuring future years lost from sudden death, and it helped policymakers look at the potential long-term gains from preventing new incident cases today. So why change it?
There were two major problems. First, it was incredibly confusing for policymakers to interpret the reports. If a health minister read a report on the burden of mental health for the year 2005, the number didn't actually reflect the health loss from everyone currently suffering from depression in their country in 2005.
It reflected a projection of future, yet-to-occur loss from only the people newly diagnosed that year.
But more importantly, there was a massive, system-breaking computational nightmare regarding comorbidity.
Comorbidity, the reality that human beings rarely have just one disease at a time. As people age, they accumulate conditions.
Right. If you use an incidence approach, you are projecting future timelines. Imagine trying to mathematically model a newly diagnosed diabetic. You project their future health loss. But what happens if 3 years from now they also develop clinical depression? And 5 years after that, they lose their vision.
Trying to mathematically predict and correct for patients developing multiple overlapping conditions in the future, all with different durations and different future streams of lost health, becomes a combinatorial explosion. It's nearly impossible to model accurately.
Moving to a prevalence approach, simply looking at who is currently sick with what conditions, right now in this given year made it mathematically and computationally feasible to handle the reality of comorbidity.
And that perfect transition regarding computational feasibility brings us to Section 4, the 22-component engine. This is all about data synthesis and advanced statistical modeling. We know the philosophy now, we know the equation, but how do they actually pull the raw data together to build this universal ledger?
It's an absolute marvel of modern epidemiology. It is an incredibly complex, interconnected system made up of 22 distinct computational components. It encompasses everything from demographic estimates of child mortality to mapping complex sequences of disease.
But before we get into the algorithms, we have to understand the philosophical stance that GBD takes regarding missing data, because the entire engine rests on how it handles the unknown.
The no data dilemma. What happens when a country's health data is terrible? heavily fragmented, sitting in dusty paper files, or just entirely missing because they don't have a functioning health surveillance system.
A traditional conservative statistician might argue you should just leave the spreadsheet cell blank, put an NA, and move on.
The GBD takes a very firm, highly intentional stance against leaving blanks. Their core operating principle is an uncertain estimate bounded by wide uncertainty intervals is infinitely preferable to no estimate at all.
Why? Because they understand human psychology and politics. If you leave a cell blank on a major global health report for, say, maternal mortality in a specific rural province, local politicians and policymakers do not look at that blank space and interpret it as, oh, we have a gap in our epidemiological surveillance. We need to invest in better data collection.
No, they interpret a blank space as a zero. They assume there is absolutely no burden from that condition, and therefore it requires zero funding, zero interventions, and zero political attention. A blank space actively harms populations by making their suffering invisible.
Exactly. To combat this, the GBD researchers systematically scour the earth to identify all published and unpublished data. They use government registries, household surveys, scientific literature, and hospital records.
But health data is notoriously messy.
When you synthesize data from hundreds of different countries, you have to deal with massive errors. And what's fascinating here is that sampling error, the standard statistical margin of error you get because you only surveyed a small sample of the population rather than everyone, is actually a much smaller problem than what we call non-sampling error.
Let's dive into non-sampling error. This is the messy, on-the-ground reality of global health research. We're talking about severe variations in case definitions. A systematic review might look at the global prevalence of diabetes, but the researchers discover that the 50 underlying studies they're pulling from used 18 completely different clinical case definitions for what constitutes diabetes.
We're talking about vastly different diagnostic technologies. Some well-funded urban hospitals diagnose a myocardial infarction with highly sensitive troponin blood tests, while a rural clinic might only have an ECG or just a symptom checklist.
We're talking about recall bias in patient surveys. You cannot simply take raw numbers from these wildly different studies and add them together without massive mathematical adjustments.
It would be garbage in, garbage out. The GBD has to build complex statistical crosswalks to map and adjust all this disparate bias data into a single comparable reference standard definition.
And a huge proportion of this data synthesis effort involves cause of death data. This brings us to a crucial epidemiological tool used heavily in low-income areas where vital registration systems like formal, medically certified death certificates simply do not exist or are woefully incomplete. It's called verbal autopsy, or VA.
Verbal autopsies. I want to paint a picture of this for the listener. Imagine a trained local health interviewer walking into a remote rural village. Someone passed away a few weeks ago without ever seeing a doctor. The interviewer sits down with the grieving relatives. They use a highly structured, standardized WHO questionnaire to ask about the specific sequence of signs and symptoms the person exhibited in the days and weeks before they died.
Did they have a high fever? Were they coughing up blood? Did they have seizures? For how long?
It sounds primitive compared to an MRI, but validation studies show that for many distinct acute causes of death, like tetanus, measles, or severe trauma, verbal autopsy performs remarkably well in ascertaining the underlying cause when no medical professional was present.
It's an essential tool for shedding light on the uncounted. But even in high-income countries, even when you have formal computerized death certificates filled out by attending physicians, you run into the massive, pervasive problem of garbage codes.
Garbage codes. I always love this term. It sounds so aggressive for epidemiologists. It sounds like a personal insult to the doctor who filled out the paperwork.
It is a bit blunt, but it is entirely accurate. A garbage code is an ill-defined or intermediate ICD code that has been incorrectly assigned as the primary underlying cause of death on a certificate.
For instance, a rushed, exhausted resident might fill out a death certificate and list heart failure or cardiopulmonary arrest or septicemia as the primary underlying cause of death.
Well, biologically speaking, everyone's heart eventually stops failing. Septicemia is a mechanism. Those are immediate or intermediate modes of dying. They are not the underlying root cause.
The true underlying cause that initiated the chain of events might have been chronic ischemic heart disease, or a neglected Chagas disease infection, or an infected surgical wound.
Or you see even vaguer codes. Someone might be coded as dying from senility or old age or essential hypertension. If the GBD researchers simply took the national vital registration data at face value and left all those garbage codes as they were, It would completely ruin the comparative ledger between countries.
One country might look like it has zero ischemic heart disease simply because their doctors overutilize the heart failure code, so the GBD has to redistribute them.
They use extensive scientific literature, expert pathophysiological judgment, and complex statistical mapping to mathematically reassign those ill-defined deaths to the specific probable target causes. They literally clean the garbage out of the ledger so we can see the true picture.
Once the data is finally cleaned, crosswalked, and mapped, they face the monumental task of estimating the actual causes of death across all age groups, both sexes, every country, and every year. And to do this, the GBD 2010 update introduced a revolutionary statistical approach called CODEM. That stands for Cause of Death Ensemble Model.
Okay, let's unpack CODEM using a relatable analogy. Think of the famous Netflix prize algorithm from years ago. Netflix offered $1 million to any team of data scientists who could significantly improve their movie recommendation algorithm.
The team that ultimately won didn't just build one super smart monolithic model, they built an ensemble.
They realized that predicting human preference is so chaotic and complex that no single statistical model works perfectly for every type of user. Some models were great at predicting action movie fans, others were good at indie films, so they blended them.
That is exactly the theoretical mechanism behind CODEM. Historically, a single researcher would subjectively pick one specific statistical model, say, a standard regression that they personally felt was best for modeling malaria. But CODEM removes that human subjective bias.
Instead of picking one, CODEM tests hundreds, sometimes thousands, of plausible statistical models. It uses mixed effects models. It uses spatial temporal Gaussian process regression. It throws a massive array of mathematical models at the data, testing different combinations of covariates like maternal education, GDP, and sanitation.
But if it creates hundreds of models, how does the system know which ones are actually telling the truth and which ones are just mathematically hallucinating?
Through a rigorous process called out-of-sample predictive validity, it is a brilliant safeguard. The algorithm takes the historical cause of death data and it purposefully hides 30% of it. It locks it away. It then trains the hundreds of models on the remaining 70%.
Once the models are trained, it asks them to predict the 30% of the data that was hidden. The models that accurately predict the withheld data, the out-of-sample data they've never seen, are proven to be objectively robust.
CODEM then blends the best-performing models together into an ensemble to generate the final, highly accurate estimates. It lets the data decide the model rather than the researcher.
That handles the fatal side of the ledger, the YLLs. But what about morbidity? What about estimating the prevalence of millions of people living with non-fatal disease sequelae? For that, they developed a different analytical tool called DisMod-MISMOR.
DisMod-MR is a Bayesian meta-regression tool. Its primary, overriding job is to enforce internal epidemiological consistency. Earlier, we established the rule that you only die once. Well, there are strict laws of mathematical equilibrium in epidemiology regarding living, too.
The incidence of a disease, the prevalence, the rate of remission, and the average duration of the disease are all mathematically locked together.
I like to think of epidemiology here like a plumbing system. Imagine a large bathtub. The water flowing continuously from the faucet into the tub is your incidence, the new cases occurring.
And the water currently sitting in the tub is your prevalence, the existing cases.
Right. And the water draining out the bottom represents either remission, where people get cured, or mortality, where they die.
That is the perfect analogy. And because of the laws of physics, or in this case mathematics, you cannot have a massive tank of water, high prevalence, if the faucet is barely dripping low incidence and the drain is wide open, high mortality. The math simply will not balance.
DisMod-MR is the master plumber. It takes all the messy, contradictory epidemiological data from different studies and forces it through a series of differential equations. It checks the water pressure. It ensures that the parameters are internally consistent across regions, age groups, and time periods.
If a study claims a massive prevalence but low incidence, DisMod-MR will adjust the estimates based on the totality of the evidence to ensure the bathtub math works.
And finally, to close out the engine room, we have to talk about how the GBD handles the reality we discussed earlier. Comorbidity. This is component 16, comorbidity simulation. We touched on this when discussing the shift to prevalence. If you have a patient with multiple conditions and you simply add their disability weights together, you run into an impossible mathematical scenario.
Exactly. Let's take a patient who suffers from severe vision loss, which has a high DW, major depressive disorder, also high DW, and severe congestive heart failure. If you use simple additive math and just stack those disability weights on top of each other, you might easily generate a combined score higher than 1.0.
Which means you are mathematically defining their daily life as being objectively worse than being dead, which breaks the 0 to 1 scale.
To solve this, the GBD does something incredible. They simulate 20,000 hypothetical individuals for every single age group, sex, country, and year in their database. They take the prevalence data for every disease and use those as probabilities to model the co-occurrence of these conditions in this massive simulated population.
It's a massive Monte Carlo simulation.
Yes, a Monte Carlo simulation. And crucially, when they calculate the combined burden for one of these simulated individuals who has 3 diseases, they use a multiplicative function rather than an additive function.
Without getting bogged down in the algebra, a multiplicative function ensures that as you add more and more diseases to a person, the combined disability weight approaches 1.0 asymptotically, but it never actually exceeds 1.0.
It accurately reflects the compounding, agonizing nature of human suffering without breaking the mathematical boundaries of the ledger.
Okay, take a breath. We've built the ledger, we have established the philosophy, and we know how the engine works. Let's transition to Section 5, upstream engineering. We have spent all this time talking about measuring the outcomes, the deaths and the disabilities. But public health is not just about counting the sick. It's fundamentally about upstream prevention.
We need to look at what causes the outcomes, the risk factors. The conceptual framework you need to visualize here is linear. Risk leads to exposure, which leads to the outcome.
If we want to engineer prevention upstream, if we want to stop the stroke before it happens, we have to be able to quantify exactly how much of the disease burden is attributable to specific behavioral, environmental, or metabolic risk factors. And to do that, the GBD methodology uses a theoretical concept called the Theoretical Minimum Risk Exposure Distribution, or TMRE.
TMRED. It's a mouthful of a statistical acronym, but the underlying concept is actually quite elegant. It's a counterfactual. To measure the true health burden of a specific risk factor, let's use smoking as the classic example you have to compare the current real-world exposure in a population against an alternate hypothetical reality.
The counterfactual is the lowest theoretically possible risk distribution that could exist in a population.
Precisely. So for smoking, the theoretical minimum exposure is 0. In our alternate reality, absolutely nobody smokes. You measure the actual burden of smoking by calculating the mathematical difference between the health of the population as it currently is, with all its lung cancer and COPD, and the health of the population in that alternate counterfactual scenario where exposure is at the absolute theoretical minimum.
And they apply this TMRED methodology to dozens of risk factors: high blood pressure, alcohol use, air pollution. And when the GBD applied this and compared the ranking of global risk factors between the 1990 data and the 2010 data, that exposed a fascinating, monumental shift in human behavior and risk.
It was a massive shift that redefined global health priorities. In 1990, childhood underweight, a direct marker of severe poverty and malnutrition, was the unequivocal leading risk factor globally for disease burden. But by 2010, just 20 years later, childhood underweight had plummeted down the rankings.
It was replaced at the absolute top of the ledger by dietary risks. And it's important to note, dietary risks in the GBD isn't just one single thing. It is a complex cluster of 14 different specific components. It includes diets low in fresh fruit, low in nuts and seeds, and diets dangerously high in sodium.
Right alongside those dietary risks, we saw high blood pressure and smoking rise to the very top of the global risk rankings. This perfectly mirrors the macro-epidemiological transition we discussed way back in Section 1.
The risks driving human suffering are shifting away from those associated with extreme poverty and undernutrition and moving rapidly toward risks associated with metabolic changes and lifestyle factors. We are eating differently, we are moving less, and our blood pressure is rising.
But there's a vital, slightly hidden global nuance here that policymakers have to understand, particularly with a risk factor like smoking. If you simply glance at the global rank of smoking between 1990 and 2010, it looks completely static. It stayed right near the top of the list both years.
An untrained observer might look at that flat global trend line and conclude, well, the billions of dollars we spend on anti-smoking campaigns and taxation aren't doing anything. The burden hasn't moved.
But that static global rank is an illusion. It masks a crucial diverging dynamic underneath. Smoking rates and the massive health burden associated with them are indeed falling significantly in high-income countries. Decades of aggressive public health interventions, advertising bans, and heavy taxation are working in places like the US and Western Europe.
But, mathematically, those massive public health gains are being almost entirely offset on the global ledger by rapidly rising smoking rates in low and middle-income countries. As regulations tightened in the West, the global tobacco industry aggressively shifted its marketing focus to vulnerable populations and LMICs, and the global GBD ledger captures that tragic reality perfectly.
It's a sobering realization of how interconnected global markets and global health truly are. Which leads us perfectly into our final major topic, Section 6, making sense of the ledger. We have all this data, billions of estimates. How do we interpret it and actually use it for policy impact?
The Institute for Health Metrics and Evaluation, the IHME, the incredible organization based in Seattle that coordinates the massive GBD effort, created a suite of visualization tools to solve this. They built GBD Compare, which utilizes interactive tree maps, heat maps, and complex arrow diagrams.
And it is so important to stress that these are not just pretty pictures designed for academic presentations. They are essential tools for real-world translation. A health minister or a local hospital administrator is not going to sit down and read a raw SQL database of a billion estimates.
They need to see a tree map, a proportional square pie chart that immediately visually shows them the exact distribution of burden in their specific country, broken down by color-coded categories.
When you use these visualization tools to look at the grand global shift from 1990 to 2010, the picture is visually striking. We talked about communicable diseases dropping, but looking at the top absolute daily causes globally in 2010, ischemic heart disease and stroke have decisively taken the top two spots. They are the great killers of our era.
But perhaps even more stunning than the rise of cardiovascular disease is the dramatic rise of conditions that cause massive chronic population suffering but almost zero mortality. I'm talking about the dramatic rise in the rankings of major depressive disorder and low back pain.
This specific finding is exactly why the daily metric is so revolutionary and vital. Major depressive disorder generates virtually zero YLLs. It does not directly kill people in the acute immediate way a myocardial infarction does.
Exactly. If we still lived in the 1980s and we only measured public health success by mortality rates, clinical depression wouldn't even register as a top global priority. It would be invisible to health ministers.
But because it causes massive, profound, chronic suffering over years and decades, it generates huge amounts of YLDs. It becomes a top global burden demanding psychiatric resources, clinics, and research funding.
And this brings us to a critical final differentiation for decision makers analyzing this data. You have to understand the difference between volume and rate. When you are looking at the GBD data dashboard, you have to know which metric you actually need to answer your specific question.
Let's break this down meticulously because getting this wrong leads to disastrous policy. Volume is the absolute number. It is the raw total sum of dailies or deaths.
Volume is crucial for on-the-ground health service planning and absolute resource allocation. If you are a hospital administrator or a regional health planner, you absolutely need to know the volume.
For example, the GBD data shows that between 1990 and 2010, the total absolute volume of dailies caused by stroke increased significantly worldwide. So as an administrator looking at that volume, you know you need to physically build more stroke wards, you need to hire more neurological rehabilitation specialists, and you need to purchase more MRI machines. The absolute number of sick people walking through the door is going up.
But, and this is the crucial pivot, if you are a public health official, the person in charge of evaluating whether your prevention interventions are actually looking at volume will deeply depress you. You will look at the rising volume of stroke victims and think your national stroke prevention programs are completely failing.
That is why the public health official must look at age-standardized rates.
Age-standardized rates use mathematical weighting to remove the demographic drivers of population growth and population aging. They level the playing field so you can look at the true underlying epidemiological trend. And when you look at the age-standardized rate for stroke globally between 1990 and 2010, it actually dropped by an incredible 23%.
Wait, let me make sure the listener grasps this because it seems like a paradox. The absolute volume of stroke went up, but the rate of stroke went down by 23%.
That is a massive public health victory. It means the clinical interventions, the widespread use of statins, better blood pressure control, aggressive smoking cessation campaigns, they are actually working beautifully. The underlying biological rate of stroke is falling.
Precisely. But because the global population is growing larger, and far more importantly, Because the baby boomer generation is aging rapidly into the high-risk demographic zone for stroke, that massive demographic shift is mathematically outpacing the epidemiological gains we are making. So the individual risk, the rate, drops. But because there are simply so many more older people alive, the absolute volume of strokes still goes up.
If you do not differentiate between volume and rate, you will completely misinterpret the reality of the situation. You might cancel a highly effective statin program because the stroke volume was rising, not realizing the rate was actually plummeting.
It perfectly highlights the dual, somewhat contradictory challenge of modern public health. We have to continue pushing the rates down through aggressive upstream prevention, while simultaneously scaling our physical hospital infrastructure up to handle the sheer volume of patients driven by an aging world.
All right, we have covered an immense amount of ground today, from the universal ledger to the complexities of Bayesian meta-regression. Before we wrap up, let's do something a little different. A quick mental check. I'm going to throw a few rapid-fire scenarios or questions at you, the listener, based on what we just discussed. See if you can recall the core concept. I will pause for a second, you think of the answer, and then we will walk through it together and tell you exactly where in Chapter 5.17 of the Oxford textbook you can read deeper. Ready?
Prompt 1. Think back to the very beginning. What is the primary fundamental reason the GBD framework insists on rescaling disease-specific mortality estimates provided by different organizations? I will pause for a second.
The answer is to ensure they strictly match the all-cause mortality envelope. Remember our golden rule, you only die once. If you need to review the mechanics of how they enforce this, refer to the section on estimation principles in Component 9 in the textbook chapter.
Prompt 2. Let's talk ethics. In the massive GBD 2010 update, which specific standard was chosen by the ethicists to determine years of life lost across all global populations, replacing the old Japanese tables? I will give you a second.
The answer. They adopted a single, unified standard life expectancy of 86.0 years for both sexes, which was based on the lowest observed mortality globally. For a deeper dive into this philosophical shift, refer to the section titled Value Choices and Population Health Metrics.
Prompt 3. This one is about the math of human suffering. How does the GBD 2010 methodology mathematically address the issue of an individual having multiple overlapping morbidities to prevent their combined disability weight from exceeding 1.0? Think about it.
The answer. By utilizing a massive Monte Carlo simulation of 20,000 hypothetical individuals, and crucially, applying a multiplicative function rather than a simple additive function for the combined weights. This mathematical elegance is detailed in Component 16, Comorbidity Simulation.
Prompt 4. Let's test your memory of the engine room. What specific statistical methodology does CODEM, our Netflix algorithm analogy, use to generate highly accurate cause of death estimates? Here's a pause.
The answer is ensemble modeling. It systematically tests hundreds of statistical models and then blends them together based strictly on their out-of-sample predictive validity. You can review this in Component 8, Estimating Causes of Death.
Prompt 5. Put yourself in the shoes of a health minister. When evaluating a public health intervention's true epidemiological impact over a decade, independent of population growth and aging, which specific metric should you utilize? Think for a second.
The answer. Age standardized rates. Remember the stroke example. This critical distinction for policymakers is covered in the section Exploring GBD Results and Key GBD Results.
Prompt 6. Final question. Why did the GBD 2010 architects make the monumental decision to shift from an incidence approach to a prevalence approach for measuring non-fatal health loss, the YLDs? Final pause.
The answer. To make it computationally feasible to correct for comorbidities across lost health streams of vastly different durations. Projecting future multiple diseases was impossible. Counting current ones is manageable. This structural change is found back in the Value Choices and Population Health Metrics section.
Excellent. I hope those mental checks help solidify the vast conceptual frameworks we've built today. As we wrap up this deep dive into the universal ledger of human health, we want to leave you with a final, slightly provocative thought to carry with you.
This final thought builds on everything we've meticulously unpacked today. We have talked extensively about the complex math, the Bayesian models, and the survey methodologies. But never, ever forget that measurement itself is an act of power. In the high-stakes realm of global public health, what gets measured gets noticed. And what gets noticed gets funded.
The formulas we use to calculate a single daily, the philosophical choices behind standard life expectancies, the rigorous algorithmic processing of messy garbage codes, these aren't just dry academic exercises in mathematics. They are the invisible scaffolding of global health policy.
They literally dictate which maternal clinics get built in rural villages, which psychiatric research programs get vital grant funding tomorrow, and ultimately, which human lives are prioritized. Quantification is deeply scientific, yes, but it is inherently, inescapably political.
That is a profound perspective to carry with you, whether you were stepping onto the hospital wards tomorrow or stepping into a policy briefing.
Thank you for joining us on this conceptual deep dive. We highly encourage you to go explore the interactive visualizations on the IHME website to see these incredible numbers actually come to life. Here are the details of this episode.
Global burden of disease methods. Byline. Measuring what matters, how public health quantifies illness, disability, and premature death across populations and nations. Episode description. In this episode, Medlock Holmes steps onto a global stage. Instead of a single outbreak or local study, we now examine the health of entire populations across countries, decades, and causes. The Global Burden of Disease (GBD) framework was developed to answer a profound question. How do we compare the impact of different diseases, injuries, and risk factors on population health? Mortality alone is not enough. Disability matters. Years lived with suffering matter. Premature death matters. Holmes guides us through the core metrics that transform global health measurement. Years of life lost, YLL, quantifying premature mortality. Holmes guides us through the core metrics that transform global health measurement. Years lived with disability, YLD, quantifying non-fatal health loss. Holmes guides us through the core metrics that transform global health measurement. Disability-adjusted life years, they're the combined measure. Holmes guides us through the core metrics that transformed global health measurement. We explore how these metrics allow comparison across diseases as diverse as malaria, depression, road injuries, and cardiovascular disease. Holmes explains how age standardization, life tables, modeling, and systematic data synthesis are used to generate comparable estimates across countries with varying data quality. The episode also examines the challenges of GBD work. Incomplete data systems. The episode also examines the challenges of GBD work. Cause of death misclassification. The episode also examines the challenges of GBD work. Uncertainty intervals. The episode also examines the challenges of GBD work. Cultural variation and disability weighting. The episode also examines the challenges of GBD work. We conclude by examining how GBD results influence policy prioritization, funding allocation, and global health strategy, and why measurement itself is an act of power. The episode also examines the challenges of GBD work. In public health, what gets measured gets noticed. What gets noticed gets funded. The episode also examines the challenges of GBD work. Key takeaways. The episode also examines the challenges of GBD work. The Global Burden of Disease framework enables cross-disease comparison. The episode also examines the challenges of GBD work. GALE ways combine premature mortality and disability into a single metric. The episode also examines the challenges of GBD work. Age standardization ensures fair comparison between populations. The episode also examines the challenges of GBD work. Modeling compensates for incomplete or inconsistent data sources. The episode also examines the challenges of GBD work. Uncertainty intervals are integral to responsible interpretation. The episode also examines the challenges of GBD work. Burden measurement directly influences policy priorities and funding decisions. The episode also examines the challenges of GBD work. Quantification is both scientific and political.